Depression and bipolar disorders in children and adolescents. Good morning. This topic that I'm assigned with includes both children and adolescents. Very, very wide-ranging topics, so therefore I will try to summarize and use more precise sentences. The other day, if you participated in Del Bello's course, the majority of what I'm going to be saying has been talked about in that session. Therefore, I will try to delve into certain parts of the topic, and I will be investigating the other parts. Now, depression and bipolar disorder in children and adolescents, we have begun to come up with more diagnoses. We should try to understand why. When we say resistance, with regard to scientific philosophy, in fact, if there's no resistance, there's no disease. The other problems and symptoms that we define, should we be including them in the disease spectrum? And when we assess them with regard to scientific methodology, do we assess those two disorders with what is present or what is absent? For instance, in a room, should I look for who is here, for instance? Is that he's here? Or should I look for who is absent? If the majority, most of the hall is empty, then I should be concentrating on the present ones. In bipolar disorder, we again look to see what is present, because controlled, blind and placebo-controlled studies are limited, and most of what is being practiced is being adapted from adulthood. This will be the data that we'll be confronted with. Now, when we look at the basic concepts, what is response to treatment? What is resistance to treatment? Response means no matter with what you measure the symptoms, be it scales or clinical observation, if there's less than 50% reduction in symptoms, we say there's no response. Whereas response is more than 50% response or full response. Remission means wellness period that lasts between 2 weeks and 2 months. We may say remission. In recovery, it is healing, we may say, which lasts for more than 2 months. Healing that lasts for more than 2 months. For adults, this is more than 6 months. What we say relapse is an episode during the remission period. What we say recurrence is a new episode during the recovery period. So, when we look at treatment, first of all, there's an acute treatment period. After that is what we call the sustainable period, and then the maintenance period. So, resistance definitions vary according to these periods. Frequency, I'm just skipping those. So, increasingly, we diagnose this more, and of course, we may discuss the reasons, but we know that resistance to treatment, with regard to that, children and adolescents are similar with the adults. Response rate, I call. The other one we say 70% response rate. The other one we say 20% no response. These all determine our approach. There are developmental differences. Irritability is more in children, and developmental symptom may be presented differently. But where are we in treatment? In treatment, we are not advanced much. Yes, we have antidepressants, but are they perfect? No, especially in children during their developmental period, when the brain development is still ongoing. What sort of effects does it have on the brain? We don't know. But we know that antidepressants in general, when we think very primitively, this is what they do. On the very primitive level, it makes people nonchalant. It makes some people sweet nonchalance, and it makes some people rude nonchalance. But when you explain it a bit more technically, in fact, the perception of threat is reduced in people. And these may be threats about conflicts we experience within ourselves, or these may be threats, external threats. When we look at the philosophy of antidepressants, in fact, they give a sense of struggle. There's been a trial conducted on rats, sewage rats. The normal, natural compensation systems, these are impacted. It's an abnormal struggle. You know, sewage rats, when they fall into sewage, they bring their nose up and they go with the flow, and they hang on whenever they can. They don't struggle. So when we see those sewage rats given antidepressants, their struggle behavior increases, but they drown. So you have to really adjust. In natural depression, if you have too many stimulants, you should be more calm. There'll be more stimulants. You'll have to adjust your energy. You'll sleep more, etc. That sense of struggle is increased, and in a way, it's like a stance against our fate. When we look at the options, here's what we see. Studies show that well, of course, in these diagnoses, you're never sure that the diagnosis is really depression. If the physician is depressed, he may diagnose more depression. If he is problematic that day, if he has frustrated that day, there are things that have an impact on our perception. It changes the way we perceive people. So many factors come into play here. So therefore, I'm concerned about the diagnosis, because in children there's also the fact that external stressors have an impact on them. They have unhappinesses, they can't get along with other people. All these may be perceived as depression. So phenomenologically, this is a challenge for us. Drug or placebo are not too different. So all three may be psychotherapy, drug combination. We all mean mild and moderate. For severe, we have no such options. You have to have the drug. Maybe the thing that has to be criticized in those trials is that mild, moderate, severe, they are all collected in one pool, and the results are interpreted as such. And that may be misleading, and we can see that in many of the data. The latest antidepressants are not effective. Why? Because in the trials, when they take the mild and moderate groups, they see that 80% of them were not really depressive. Maybe a mood disorder kind of thing. We see that we come up with more blurred diagnoses. So these are our challenges. There are different algorithms. Algorithms, of course, are guidelines for us, but when you match them with our clinical experience, with our own experience, or with people who we trusted, when we ask, what do you do? So I rely more on the kind of data collected in this manner. A new medication comes, and I always ask my colleagues, have you used it? So you obtain a lot more information and insight with such data collection. There may be a variety of data. We tried bipolar in adult. Quetiapine is effective in the depression part. A scientist said. Another scientist said no. He said we saw no difference. So there may be lots of conflicts. There may be differences like the child and the adolescent, their developmental process, and the adult are different. We have to discriminate between those. What we define as resistance to treatment is that one is no response, which we call, when we use a medication, it's sufficient dose for a sufficient period of time, we cannot obtain improvement in symptoms. What we say resistance is to have at least 2 antidepressants from different groups, and these should be used in appropriate time frames, and there's still no healing. There are, of course, predictors. delay, because delay in depression, because children are developing, it may become their nature. If you delay, they may become an aggressive person. Dysthymia, is it a disease or is it becoming a personality model? Substance abuse, personal, family history, environmental stressors, or psychotic atypical depression. These are all reasons for resistance. There's a fake resistance, which we call. In fact, it's not resistance, but it's something based on us not managing the disease well. Maybe misdiagnosis, incompliance with treatment, inadequate drug dosage, early termination of treatment, and data tells us that 80% of resistance to treatment consists of this fake resistance, not enough dosage, not enough time, or maybe it's the patient's personality or family members' concerns. They change physicians too frequently. For instance, let's say SSRI has been prescribed, the other physician gives another SSRI. Instead of increasing the dosage of the previous one, they may shift to another one. So there may be problems with physicians. Again, overlapping psychosocial stressors, early termination of treatment and change of treatment. This is something we see frequently. This may be justified in some ways, or it's our assessment during the process that sometimes may be problematic. And I will talk about this in overlapping. So I will not go over changing, combination, reinforcement, more advanced stages. You know, there's a STAR trial performed on adults. In children and adolescents, this kind of a trial would be difficult to approve, I guess. As you know, first there is randomization when there's no response. It's really up to the people. SSRIs, receptor level, effective, SSRIs, cognitive. And these treatment options are left to the individual, which does not happen in case of children. There are two trials that we know. One is the depression in adolescents. Here, fluoxetine by itself, plus cognitive behavioral therapy, or by themselves, or placebo, and the results obtained show that fluoxetine plus CBT is better. So it is really something we know. The other renowned study is TORDIA. It's still ongoing. So reporting results here. 8-week SSRI, no response. Any SSRI will do. Let's say paroxetine. Exchange to fluoxetine, sertraline. They change it to the other paroxetine. They change it to Cipram. If it's Cipram, they go to paroxetine. So it's just a change of SSRIs and change it to venlafaxine, merging with CBT, merging with venlafaxine. Result being no difference between SSRI and SNRI. However, side effect, SNRIs have more SNRI side effects. The best thing about this trial is that it addresses a group with more suicide risk. Suicide risk in those who were in higher risk for suicide at the outset. Venlafaxine seemed to increase suicidal tendencies. The best defined diagnosed thing is the combination. Again, same things are equally valid. I don't want to repeat. For resistance, all of these general anxieties are equally valid for bipolar, about diagnostics, about developmental. All things are equally applicable. However, in childhood, bipolar is not seen too frequently. Not in the pre-adolescent phase. At least I have not seen it. But it's difficult to diagnose in adolescence, so that we have more phenotypic diagnosis. Wide, narrow phenotypes, intermediate phenotypes, symptom level diagnosis rather than categorization. So this is a disorder which we cannot predict where it will go. And in general, some trials say there's more mixed types, more rapid cycling. Apart from that, well, we can't categorize it anywhere. We should include it in the NOS group, and the majority consists of those. And various groups claim these things, but it is also said in childhood or adulthood, bipolarity does not mean that the person will end up being a bipolar adult, but diagnosis is also suspicious. So we should always be thinking in an investigative manner, but bipolar NOS and bipolar 2, they say 20% tends to become bipolar. There are other problems that it's mixed with, especially ADHD, energetic state, destructibility. They overlap 90% in both of these cases, but apart from that, grandiosity, hypersexuality, flight of ideas, so there may be differences. But always when we assess, we should give predominance to differences from earlier phases. But in the algorithm, later it says, the manic period of bipolar, you may use all three options. If you like, you directly start with antipsychotic. If not, you can start with mood disorder, or you may start with a combination. We really have a very wide spectrum choice. So it's important that we start with medications we're used to, because new ones may present us with problems which will challenge us with regard to coming up with solutions. Can we wrap it up? I'm about to finish. And among these options, maybe this comorbidity is high. They say in ADHD children, the bipolar mania is harder to treat. But there are also reservations about that. I've always had reservations about that. Really, children with ADHD, their developmental phenotypic appearance, shall we go down that road? I have concerns about that as well. Mood stabilizers, etc. After treating with them, when there's healing, stimulant treatment may be given to solve residual problems. It will never cause relapse in mania, they say. So I gave a stimulant and psychotic signs in mania. If they increase, it's mania. If there's no increase, it's ADHD. There are no clear-cut borders. I will talk about depression, if you allow me. Solving the mania of bipolarity, you solve it in a way, but the most difficult period is the depressive period. We have to solve that very well. There are reservations, manic shifts with SSRIs, olanzapine plus fluoxetine, lamotrigine in adults may be good, but in children we don't have much experience. Apart from this, ketipin-related phases come into the foreground. But in adolescents and children, if it's mild to moderate, those depressive periods should be but I don't mean the severe ones. Start with psychotherapy, then drug. I think it's beneficial. Thank you.